good afternoon, and good evening, everybody. Welcome to another week of the Global Café. My name is Elizabeth Lewis, and I'm a Senior Policy and Project Coordinator here at the IFA. And I'm very excited to introduce you all to Miss Brynn Bowman. As Chief Executive Officer of the Center of Advanced Palliative Care, or CAPC, Brynn Bowman presides over the organizational and content strategy that serves more than 1,700 CAPC member health care organizations, including over 70,000 clinicians and administrators. Ms. Bowman, previously CAPC Chief Strategy Officer, succeeds Diane E. Miner, MD. Ms. Bowman is nationally recognized leader in scaling practice and culture change in healthcare delivery for people with serious illness. An expert in palliative care education, she specializes in healthcare leadership, palliative care business and financing, palliative care program design, palliative care education for non-palliative care specialists, and palliative care delivery during the COVID-19 pandemic. Her work has been instrumental in the development of clinician engagement and education strategies to equip the U.S. healthcare workforce with the skills needed to care for patients with serious illnesses and their families. Ms. Bowman was 2020-2021 Health and Aging Policy Fellow, where she served with the Senate Finance Committee. She's co-chaired 3 of the National Academies of Sciences, Engineering, and Medicine Roundtable on Quality Care for People with Serious Illness workshops focused on workforce and the impact of COVID-19 pandemic. In 2016, she won the Brandon Hall Group Silver Excellence in Learning Award for Best Use of Mobile Learning CAPC online curriculum. And prior to joining CAPC in 2013, Ms. Bowman served as a strategy director at Level Up, a technology company specializing in mobile payment and small business marketing. Ms. Bowman graduated from Harvard College in 2008 with an AB in Biological Studies and received her MPA from New York University in 2017. So as you can all tell, Ms. Bowman has accomplished so much in her career, and we are very excited to have her to discuss achieving sustainable change for adults with serious illness. So welcome.
My goodness, we should have given you the short bio. Apologies, everybody, but it's great to be here. Good morning, afternoon, and evening, everyone. Thank you.
No, that's great. We're happy to hear everything that you've accomplished. I'm very happy to have you. So just to get us started, I want to ask if you could share a bit more about how you first got involved in the field and specifically how you got started at the Center to Advance Palliative Care.
Yeah, my story is like I'm sure everybody on the lines, which is a personal story, a family story. I grew up in the rural Midwest in a big farming family, was really close to my grandparents, and especially my great grandmother. And when I was in junior high, my great grandma Dorothy, we called her Marshall Grandma, had a stroke. And she had been living independently in her own home into her late 80s and had to transition into a nursing home. And I would visit her, and she just, what she would describe to me is feeling invisible. Not that she was receiving poor quality clinical care, but that she felt like she wasn't seen and heard as a person because the staff were busy because she was one of many. And it just struck me that we live in the United States. I read articles about sophisticated advancements in medical technologies every day, and yet we are not able to make the lived experience of a person living with an illness or a disability feel comfortable and feel personal. And that's not the wrong way. And I considered I was pre-med in college, thought that I would go into geriatrics. Along the way, worked at several technology companies where I learned about how that industry thinks about taking a change in how we do things and spreading it. And I got very interested in this idea of systems change. How can we at the systems level improve the quality of care for older adults with serious illness? And so when I came on board the Center to Advance Palliative Care at 2013, we were looking at how to reach a broader audience, how to use technology to help us do that. That fell into my skill set and my background. So it was just a very lucky accident of timing and kind of alignment of passion that got me here.
Wonderful. Thank you for sharing that. That's a very lovely story of how you got inspired, and thank you for taking the time to share that. In terms of your work at CAPC, could you describe a bit more what the mission and primary focus of CAPC is and what your role looks like?
Yeah, we were started in 1999 by our visionary field building leader, Dr. Diane Meyer, as a program office of the Robert Wood Johnson Foundation. And the
Mm.
idea was Mount Sinai had one of the pioneering palliative care programs in the US. And what the Robert Wood Johnson Foundation was interested in was establishing a program office to help scale access to palliative care around the country, to provide technical assistance to other health systems so that they could establish their own palliative care services. So
Mm.
our mission is to advance access to highest quality, equitable, person-centered care for people with serious illness. And we approach that in two ways. One is to try to equip the leaders of palliative care programs with all of the tools, data, technical assistance, peer convening that can help them be successful advocates and leaders of their programs. And then the second way that we approach that mission is to provide clinical education outside of the field of palliative care. We consider that really it's everybody's job to be addressing the palliative care needs of older adults with serious illness, and that every clinical interaction with a person with serious illness is an opportunity to improve quality of life. So we do training for health professionals outside of the field in core palliative care skills.
Okay, thank you. Yeah, that's a quite a range of things, but that's really important work. So thank you for sharing that as well. And in terms of your own direct role, what is sort of your day-to-day look like at CAPC, or what do you typically do?
Yeah, we think a lot about partnership development and working through partnerships at CAPC. If we want to bring the message about the value of palliative care for
Mm.
patients and families and for healthcare organizations, kind of outside of our choir of the field of palliative care, that means establishing partnerships. And so we might work with organizations like the American Hospital Association, professional societies, or patient advocacy organizations like the American Cancer Society,
Okay.
and help to spread that message. And so a lot of my day is having conversations with folks from those organizations to understand, what their audiences care most about relative to
Mm.
palliative care and how we might help with education or with tools.
Okay, yeah. Sounds like a lot of relationship building too, which is
That's
nice.
right.
Yeah.
Everything is relationship building.
Yeah. Before we get too carried away in our conversation, I think maybe it's important if we could just provide a bit of a broad definition of palliative care, sort of define what it is and isn't, um, in the scope of palliative care, and also maybe what the key responsibilities of a palliative care team would look like.
Yep, good place to start. So palliative care is a medical specialty focused on people living with a serious illness and their families or other caregivers. And the goal really is to provide relief from any of the symptoms or the stresses that come with a serious illness and focus on quality of life, again, for patients and families. So palliative care teams are specialty trained in skills like how to navigate difficult conversations to really understand what matters most to a patient in the context of their serious illness. Um, what are sources of suffering, whether those are physical symptoms, existential distress, social needs that are impacting the experience of illness or a person's ability to access care, legal and financial planning for a person who has a serious illness. So all of those issues are sort of within the domain of the care that palliative care teams provide.
Mm.
Palliative care teams may work on a consultative basis. So in an inpatient setting, for example, they may work with a patient and then make recommendations to their primary treating team, or palliative care teams could work on a co-management basis, and so be
Okay.
prescribing, for example, to address a patient's symptoms.
Thank you. Yeah, it sounds like many hats are worn by the care team there. And is there anything that, and the answer might be no, which is totally fine, but is there anything that people would typically think falls under the range of palliative care but is not in scope of what palliative care teams would do?
A common misperception is that palliative care is about the end of life.
Mm.
And that's not the case. What we say at CAPC is palliative care is about need, not about prognosis.
Mm.
So regardless of age, regardless of disease stage, if you have need
Hmm.
for those services, for that added layer of support that a palliative care team can provide, you should have access to palliative care. So in the United States, for a person whose illness is terminal and who is at the end of life, the
Mm.
hospice is the service that is appropriate for that patient in many cases. But palliative care teams may be working with patients for months or years prior to that point if they have
Okay.
a need for the palliative care services.
Yeah. No, I think that's a really interesting point that you make that palliative care, I think, is often misunderstood as just sort of an end of life service. I guess I'm kind of curious, what does palliative care look like across different stages of the life course, and what would that look like for somebody who's not an older adult?
Yeah. Maybe I'll take the example of a person with dementia
Sure, yeah.
as a progressive illness. So when a palliative care team first engages that patient and their caregivers, um, there may be a lot having to do with education in
Mm.
those interactions. So helping a person and their caregivers understand what they might expect as the disease progresses, what they might want to be planning for, again, legally, financially, in
Mm.
terms of the home environment. In terms of education that a caregiver would need to best support that patient. As a person's dementia progresses, there may be physical symptoms that the palliative care team can help support with. That person may be seeing multiple specialists or multiple clinical teams, and a palliative care team can help a person and their family sort of synthesize all of that information and navigate the care that they're receiving and make sure that it's really aligned with the person's goals. If a person is in late stage dementia,
Mm.
perhaps less able to communicate what's important to them or what they're experiencing on a day-to-day basis, palliative care teams, again, then can really lean in to help caregivers understand how to provide best care, how to interpret
Mm.
the behaviors of a person and manage any symptoms, any late stage decision making around care. And so the
Okay.
nature of a person's palliative care needs may evolve, very likely will evolve over time, but always
Hmm.
it's about what matters most to patients and families,
Mm.
how the team can both provide that extra layer of support to address any
Mm.
sources of suffering, to focus on quality of life, and help to coordinate across the different services that a person is receiving.
Okay, yeah. And it sounds like it's really not a one size fits all type of role where it really is catered to the needs of each person.
Very much about each person's individual life experiences. What are their sources of support,
Yeah.
resources or lack of resources, and what is important to them. So very tailored to each
Okay.
individual person.
Yeah. And also, you mentioned a bit about the caregiver perspective, but I guess I'm also curious just beyond the individual, the importance of palliative care, not just for patients, but also for their loved ones or caregivers or sort of larger social support networks.
Yeah, I think this really starts with the palliative care philosophy is that the unit of care is the
Mm.
patient and their loved ones or their
Mm.
caregivers. It is not one or the other. And
Mm.
so, while most caregivers are very proud to be in that role and to be able to support their loved one, there's a higher incidence of mental health issues for caregivers of people with serious illness because of the stressors of that role. Job and household finances can be put at risk. There can be family conflict if there's a network of support around a person. Um, and those are support needs that caregivers have that can often fly under the radar
Hmm.
in the usual healthcare system. And so, again, part and parcel with palliative care is to assess what is going on with the caregiver,
Mm.
whether any support, any education can be provided. We, at least in the United States, we rely heavily on caregivers to be sort of extenders of clinical
Yeah.
care in folks' homes. And that puts a burden and anxiety on many people that palliative care teams try to, of course,
Mm.
identify first and then provide support.
Thank you. Yeah. And in terms of, I guess, the roles again of what a care team can provide beyond, I guess, sort of references and referrals, I believe when we were talking in our meeting before, you mentioned sort of the spiritual needs of folks, and I guess I'm curious also as well how palliative care addresses spiritual needs and social risk factors for patients as well as their families.
Yeah, a key differentiator of specialty palliative care is that it is an interprofessional team providing
Okay.
that care, and that is to reflect the diversity of needs that a person with serious illness might have. So, yes, managing pain or other physical symptoms,
Hmm.
but a person who's been diagnosed with a serious illness may be experiencing existential distress. What does this mean? That I have this cancer diagnosis or that I've developed heart failure, um, may have social needs that make it hard to access best care for that illness. So, for example, lack of transportation to doctor's appointments, housing instability, or food instability. And so it's a palliative care team's first action when they meet a new patient would be to assess for all of these issues.
Hmm.
And it may be that the physician or the nurse practitioner is required to manage complex pain. It may be that the social worker ends up taking really lead on conversations with the patients who need to understand what are the social services available in their community and how can they be assembled to help that patient cope with the illness. And so it depends on what the patient's needs are. Where are their sources of strength? Where are there places that are causing them suffering? And that interprofessional palliative care team then steps in to help. Again, I keep saying it, but I provide an added layer of support.
Yeah. Okay. Yeah, thank you. And on the other side of that, I guess I'm also curious about in terms of accessing palliative care, if there are any cultural, racial, or socioeconomic factors that influence the access or perceptions of palliative care.
Yeah, that's a great question. There are so palliative care in the United States has grown by leaps and bounds over the last 30 years, and there are still major gaps in access. So in the US, palliative care really was first established on the inpatient side. So when a patient came into the hospital in crisis, that's where palliative care teams were working. Access to specialty palliative care in community settings, in clinic, visiting people's homes who have a more advanced illness has really grown a lot, particularly in the last 10 years. But the capacity of those teams is not always sufficient to meet the needs of a community. So there's still a lot of growth that we'd like to see there. Um, in terms of geographical disparities, rural areas in the US have far less access to palliative care specialists than urban or suburban. Although the use of telehealth in recent years has helped to bridge
Mhm.
some of those gaps
Mhm.
and bring that palliative care expertise into rural areas. In terms of racial differences in access to palliative care, there are a lot of researchers in the United States who are trying to get a comprehensive picture of
Mhm.
that. We've seen sort of mixed results in studies that have come out on this topic. What we do know is that perceptions of both palliative care and of hospice can be different across
Mhm.
different racial and ethnic groups. And so we think about, how to reach out to different patient populations, how to educate about the benefits of palliative care differently depending upon the population.
Mhm.
So Black American patients with serious illness, for example, um, there have been many efforts to try to engage that community outside of a clinical setting, in partnership, for example, with faith communities, or with trusted community leaders to get the word out about the benefits of palliative care, such that if the day would come when a person would need it, they
Mhm.
recognize what palliative care is, and are more likely to realize the benefit of those services.
Okay, yeah. Thank you for elaborating on that. And I guess you partly answered this in your question, so it might be a bit of a repeat here, but is there any strategies that CAPC in particular has to address the disparities in accessing palliative care across different communities? And is that is sort of a focus or strategy that they take on?
Yeah, I'm really glad you asked about this. So launched what we call Project Equity 3 years ago. Equity is a central to our strategic plan and our mission. Um, CAPSI over the years, the way that we've done our work and tried to help scale access to palliative care in general is to really get practical about what are the palliative care program design elements, leadership skills that have been effective in one place in an exemplar site, and to build tools and technical assistance to help others replicate that model and build their own high quality sustainable programs. So we're really taking that playbook and trying to apply it to disparities, not just in access to specialty palliative care, but in general, as a person walks through the health system with a serious illness, the care that they receive, the respect that they receive, the experiences that they have.
Mm,
And so what we're doing in we focus first on Black Americans with serious illness, and we've now launched a new initiative focused on Hispanic patients with serious
mm,
illness. But we query the country, the peer-reviewed literature, the gray literature. We survey healthcare organizations and healthcare leaders around the country to say, what have you done to try to address disparities for this patient population? What outcomes have you had? If you had a successful intervention, how did you do it? How did you make the case? What did it take? And then we try to break down those examples and again build tools and technical assistance so that other health equity champions can look at those examples and say, hey, we could implement that at our site.
mm-hmm.
Um, the other thing that we have really focused on in the health equity front is convening health equity champions in palliative care because it can be an isolating role. Folks face real resistance, often inside of their own organizations. And so to have a space to be able to talk with like minded champions and equity leaders and say, I'm struggling with this, has anybody
Yeah.
else been able to figure this out in your community or your organization has been, I think, a benefit to those folks.
Yeah, and can feel empowering to know that somebody sees your struggles and sees the difficulties that you have in accessing these services. So
Yeah, that's right.
that's really great. And in terms of, I guess, strategies of speaking to either community leaders or individuals, is there sort of a narrative or a strategy, I guess, that CAPSI uses to convince healthcare systems, patients, or physicians about the benefits of palliative care?
Knock on the door really loudly.
Yeah, exactly.
you know, we this has actually been a primary role of CAPSI
Mm,
since Dr. Meyer founded the organization in '99, is framing the case for palliative care. And it is the human case, what this means for a person with serious illness,
mm,
what it means for their families and caregivers, what it means for the clinician treating them, who may experience moral distress seeing a
mm,
patient who's really struggling, what it means for the organization. So there's the human case and then also the business case for
mm,
palliative care. We know that for a service like palliative care to scale, it has to be financially feasible for the organization that is fielding that service. And so we
mm,
are constantly looking to the literature, looking at new research that's demonstrating the case, integrating that into the case that we make about the
mm.
value of palliative care. And then we bring that to health system leaders. We bring that to clinical leaders from other specialties. We bring that to frontline clinicians who may be the gatekeeper who either offers their patient palliative care or doesn't, depending on their perceptions of palliative care. Um, we bring that to policymakers to educate them about the value of palliative care and those services. So we're trying to bring that case, everywhere inside of the health system
Yeah,
where folks may influence whether or not a patient gets the care.
yeah. No, a lot of advocacy work and a lot of standing up for patients, it sounds like.
That's right.
Yeah. And I'm just gonna go to a question in our chat here. And everyone else, please feel free to put some questions in the chat if you have any questions for Miss Bowman. We have a question here from Shmuel, who is one of our regulars, and he's asking how sustainable change in care can support improvement care services for older adults with serious illnesses from poor and low socioeconomic groups of the population.
Yeah, it's a really good question because, well, I mean, the the compounding difficulties if one is working with few financial resources and trying to navigate the health system and everything that comes with
Mhm.
co-pays, transportation to appointments, missed work. I mean, it can become really, really challenging for
Mhm.
families. Another thing we think about is access to caregivers at home. If a
Mhm.
person is very sick and there is no, loved one or friend who is able to simply be home with them during the day and help to support because families depend upon that income. That's a big divider across families with serious illness. And so, it's it's interesting. So for palliative care teams, one always ask about these issues. And there are simple things, and this won't sound world changing, but it's not unfortunately standard of practice. But for example, with a person with serious illness who may be on multiple medications, maybe managing multiple conditions, it's not standard of practice to sort of understand what will be the real cost to that person at the pharmacy for those medications, and can a person afford it.
Mhm.
um, and so a palliative care team would make every effort to understand that person's capacity, work with a pharmacy, try to find benefit programs that can help supplement, payment for those prescriptions to make sure that a person can get what they can afford. Um, Palliative care programs work closely with social service providers in a community to understand, are there free or low cost services that can help supplement a person's resources, so that what they can focus on is disease treatment,
Mhm.
and be getting the support they need to follow that disease treatment.
Yeah, thank you. Thank you for expanding on that. That's really important to know that this is a focus that is getting addressed. We have another comment here from Jane. Jane, if you are here and want to unmute, you're welcome to. Otherwise, I can read your comment.
Thank you. This is just wonderful, and the foundation that I'm with is just a proud supporter of CAPSI and all of the work and where they have come. And Brynn is just such a star, and we could go on about other things that she's done. But Brynn, I would just let you know that on other IFA global cafes, there's been a couple of conversations about in other countries, palliative care is like is a right and widespread available. A lot of people can provide palliative care in communities and palliative care specialists, and that we've medicalized it a lot in the United States, making it less widely available and expensive. And I've always wanted to ask you that, even though we have conversations now and then. I just wanted to say your thought of a community available palliative care versus how we have set it up. We, being the United States, have set it up here.
Yeah, well, yes, palliative care is a human right, and every person who has a serious illness should have access to those services. I think the irony there is that, uh, at least in the US, so much of the early history of palliative care is looking around and seeing patients who are getting best disease care, getting the best treatment for their heart failure, for their cancer, and yet all of these other facets of a person's lived experience and their priorities and preferences as they walk through management of that disease can fall by the wayside because they are not somebody else's job. And because what we pay for is treatment of the illness. And so I think palliative care emerged into those cracks as saying there are real gaps in the care that we're providing for very sick people, and that's not right. Uh, and for the very same reason, it can be difficult in the US because, those services that are most highly reimbursed are medical services and medical interventions. A palliative care team may spend an hour talking to a patient about their goals of care if they're facing a treatment decision, or if they have family conflict, for example, that needs to be resolved. And that's not a highly reimbursed service in the US. And so the very influences that led to the necessity of or the acute necessity of palliative care in the US then put it at risk of what you're saying, Jane. I will say that inside of the palliative care field, I know so many just staunch defenders of the idea that palliative care is best delivered by an interprofessional team, and that is how you address those spiritual, social, ethical issues that patients face. And so I think there is, you're absolutely right. There's a tension here. Um, the other part of this picture, though, is all the clinical education that CAPSI and others provide. In my opinion, any person with a serious illness, their physician and their clinical team should be talking to them about what matters most to them, what is important to them, what are their sources of suffering whenever they have an interaction with that patient. And so we really, I think it is a two-part answer. Palliative care is a service that's appropriate for patients with a high level of need, and the rest of healthcare should be better equipped than it is to address those basic palliative care needs as a person, walks through their care journey with their illness.
Thank you so much for that. And hopefully that answered your question as well there, Jane. Perfect. Um, my question as well now is in terms of folks who are either listening to our cafe right now or just more generally, how how can patients or families understand their right to ask for palliative care? And sort of what would one go about doing, I guess, specific to the US context? What would one go about doing if they're feeling like this sounds like something that I might be interested in?
Yeah. We encourage patients and families and do a lot of education about this to
Mm,
ask for palliative care if they want it, if they think they would benefit. CAPSI has a website for health professionals where we provide our tools and our training. We also have a website just for patients and families. It's called
mm,
getpalliativecare.org. You can answer a short quiz that asks, is palliative care right for me? You can read stories, watch videos, hear recordings of what patients' experiences were before and after they were working with a palliative care team. So we do encourage patients who want it to ask for it. We offer a provider directory where, and this is limited to the United States, but you can go in and enter your state or your city or your zip code at your care setting and find information about the palliative care teams working near you. Um, we also do a lot of education to the rest of the health professional community about what is palliative care, how do you
mhm.
work with palliative care teams, which patients are appropriate for referral to palliative care. Because again, you're not going to get that referral to palliative care unless your treating clinician understands what it is and that you would
Right.
benefit. Um, this has changed a lot over time for clinicians going through training right now. They're very likely in an academic center where they see the palliative care team at work day in and day out and really understand what that means for patient care. For clinicians who trained before there was reliably a palliative care service
Mm,
in those teaching sites, there's more continuing education needed about that. So we see this changing over time. But again, core to our mission is just education for
mhm,
anybody who could serve as sort of the gatekeeper of whether
mhm,
patients get palliative care or not.
mhm. Thank you for that. And another comment here from Jane that I do want to expand on here. She says age-friendly care and palliative care go hand in hand. And, at the IFA, we do a lot of work in age-friendly environments and frameworks. And I guess you've mentioned a bit about expanding the scope of care and what community looks like, but could you sort of make that connection for us of how it is connected to the age-friendly framework?
Absolutely. At the very end of the day, palliative care is about what matters most to patients and to help the care that a person receives align with those care goals or those care priorities. And that is exactly the foundational principle of age-friendly health system. The
Mhm,
first of the M's under age-friendly is what matters to patients. And so there's a lot of alignment. While palliative care teams there are pediatric palliative care teams. Palliative care teams see patients, younger adults who have a serious illness. The large majority of our patient population with serious illness are older adults.
mhm,
And so a ton of sort of philosophical alignment and service alignment. And I think it's no accident that in the US, many of the organizations and the healthcare leaders who are the biggest champions for age-friendly healthcare are also exemplars in palliative care delivery
Right.
and the biggest palliative care champions. And
Thank
that
you.
I have to thank Jane here because the John A. Hartford Foundation has done such an incredible job raising attention and engagement around age-friendly care.
Yeah. And she says again in the chat, then palliative care is the original age-friendly care, which is a great point.
I love it.
Yeah.
Um, I saw Catherine had a great question in the chat too about the effect of for-profit
Yeah,
healthcare
no, great
on
question
palliative care.
From Catherine there as
You
well.
don't
Catherine,
mind if I go rogue?
no, of course, of course. Yeah, Catherine, do you want to read your
Oh,
question?
well, Brynn, you've kind of touched on it. I live here in New York City, and one healthcare system after another is gobbling up all the rest of the smaller hospitals and the increasing pressure on doctors. And talk to them as they're leaving these hospitals is not that what they want to do and love to do, but they're being pressured because of the financial investment of these large corporations with very well-paid CEOs, is that they feel they can no longer practice what they want to. So I wondered what's the impact that you see maybe around other places than New York City? Is this something that we really should be concerned about? Thanks.
No, thank you. This is a question I think about nonstop. I think we really should be concerned, both in terms of the well-being of professionals, and like you say, whether folks are able to continue in their work. I think what we see a lot on the palliative care side is not just overwork based on sort of the pressure to work towards financial metrics, but just moral distress at feeling like teams are not able to provide the quality of care to patients that you know they were trained to believe is appropriate because of those pressures that you're talking about. So I think in some ways, palliative care teams are going through it on this issue, just like everyone else working in healthcare. There is the added pressure in palliative care of there are no requirements for palliative care in the U.S. under any payment framework or any care setting. Um, there is a business case for palliative care. Again, CAPC works very hard to make this case. Um, but you look at a hospital that's providing palliative care, for example, that's an initial investment that then pays returns because, for example, patients who are set up with a palliative informed discharge plan are less likely to be readmitted to the hospital. That's a financial benefit to the hospital. Palliative care teams are able to help long stay patients safely and comfortably leave the hospital and be discharged back home. Again, all things that have financial benefit to that hospital, and yet non-for-profit hospitals are more likely to make that investment than a for-profit hospital. So the lack of requirement for access to palliative care is a barrier here. And it kind of almost counterintuitively during the pandemic, um, a lot of organizations and clinical teams came to really rely on their palliative care teams managing shortness of breath, talking about care decisions with families, usually over a Zoom call because visitation was so restricted. So came to see that palliative care team as really critical support for very sick patients through those clinical relationships. And of course, that sustains once we get out of the public health emergency. So palliative care teams are being consulted on more patients these days, and we are surveying the field every year to ask about this. But team size isn't growing. Investment in the palliative care service isn't growing. And so, sort of one hurdle has been cleared of folks really get it, really understand that their patients would benefit from palliative care, and yet teams are being asked to do more with the same, or in some cases less, and that falls back to financial pressures in the health system too. So it's a tough nut. I will say there are some other ways that in which things have improved in the U.S. Just in recent years. For example, um, Medicare 2 years ago published new billing codes for caregiver education, for assessing for social determinants of health, for care navigation. Those are services that palliative care teams have always been providing their patients. have never been reimbursed for, are really important to patient and family experience. And now, the reimbursement is low, but it's there, and it used to be zero. And that's, I think, a reflection that Medicare understands how critical those coordination education services are to people. So that's an example of something that has moved in a positive direction recently. Um, Again, it's not earth shattering, but a positive signal.
Thank you so much. And I see another great question here from Willisteen that I want to get to. Just a question while we're still on the same topic first. Would you say these changes were impacted by the COVID-19 pandemic, or are there any sort of, I guess, larger challenges or opportunities that the COVID-19 pandemic has presented for palliative care teams?
Yeah, again, I think the pandemic ended up resulting in sort of raising the visibility of the work of palliative care in the
Mm.
popular press. I mean, there were Washington Post, New York Times, journal articles about uh, goals of care conversations and what that meant to patients' experiences, or thinking about a patient on a ventilator, and what the information their family was receiving. And so I think there was a spotlight shown on palliative care in a way that was kind of new. Um, so the number of press hits went up. Again, the number of consults to palliative care programs went up. Um, because, and especially in the beginning of the pandemic, we didn't have treatments for a disease. We had a lot of suffering. And, palliative care teams would step in, talk about goals, manage shortness of breath, communicate with families in a way that was really meaningful for patients and families. So I think raised visibility, strengthened clinical relationships. Often palliative care teams were part of the critical response, sort of strategic team inside of an organization or a health system, thinking about, okay, a patient who had cancer prior to the onset of the pandemic, it's now not safe for that person to enter the hospital. How can we make sure that they get what they need at home?
Yeah.
The medication, the care, the 24/7 number to call, so that they're less likely to have an emergency and need to come into an acute care setting. And again, that's raised the visibility of palliative care leaders as really being expert on the needs of seriously ill older adults. And then again, the next step, I think, is appropriately resourcing those efforts so we can make sure that they're sustainable.
Yeah. No, that's really interesting. Thank you for sharing that. And I'll go back to Willisteen's question now. If you want to unmute and read your question, you're welcome to. Otherwise, I'm happy to read it aloud as well.
Hi everybody.
Hi.
I asked the question, I don't remember everything I put in the, okay. It's about palliative care. What would it look like in a long-term care facility? I'm a retired nursing home administrator.
Oh,
I don't remember all the pros and cons of how treatment is done with Medicaid, Medicare, et cetera, but for for a certain population of our society, those that are in long-term care, what would palliative care look like in a nursing home? How could it be attained? Because there are financial restraints and laws and regulations, etc. What would be some of the things a nursing home caregiver, a nursing home residence caregiver or family member could do to add to the care in the nursing home if it cannot be through a funded process?
it's such a good question. There is so much need, and there is unfortunately much less access to specialty palliative care today in nursing homes than in other settings. There are a few of kind of a spectrum of models, that I've seen and I'm aware of, and I would love for anybody else to weigh into the chat, or come online to talk about what you're doing or seeing. Um, One is consult relationship. So it may be the case that a nursing home partners with a local hospice that has a non-hospice palliative care service line that makes home visits. And they consider that nursing home to be the patient's home, and they make visits to the nursing home the same way that they would to a private residence. And so that requires some operationalizing in terms of how is clinical communication happening. What is the sort of negotiated agreement between that palliative care organization and the nursing home? But there are sites that are doing this really successfully. In some, and I haven't seen this very often, I have to admit, but I know of a couple of examples of health systems, whether they own the nursing home or whether the nursing home is simply a sort of a major source of patients coming into the emergency department or being admitted. Well, they'll have a relationship where that inpatient palliative care team will do telehealth consults with a nursing home resident who may be experiencing a symptom crisis, for example. And the question on the table is, should this person, should we be calling the ambulance and should they be brought into the emergency department? It's not what the resident is looking for, but it may be medically necessary, and the palliative care team can, in that instance, through a telehealth encounter, help the staff at the nursing home kind of support that decision making. There are nursing homes that have wonderful education programs for staff around palliative care skills. A lot of that is communication and symptom management, and just assessment for sources of distress that can then be either addressed by clinical staff or by a partnering palliative care program. So, it's a tough environment because of the resource restrictions that you mentioned. And I will see, I would love to hear if any of those sound feasible to you or what your reaction to that is, because we've thought about this and worked towards this for a long time at CAPC, and it's tough. It's tough to operationalize.
That really hits it. Now that I'm retired, but not retired from gerontology, it's one of those things that's on my list of things to be an advocate for in some type of way, because I think I've seen it on both sides of the aisle, as they say, from the professional, seat, and also from, well, personally as a caregiver. The educational part intrigues me. I would like to, with your organization or those that are interested, really look into that and just start with grassroots. I won't say movements, grassroots approaches to educate. And I think education is a key thing. Sometimes it's not the money, but if people know it, they know it. Sometimes you have to pay for it, and sometimes you don't. So I'm definitely interested in the palliative care piece. I was a part of the hospice program in Washington, D.C. many, many years ago with the Washington Home. And so I trained the volunteers to be hospice volunteers, in the hospice unit. So I'm interested, and I'd like to hear more about what can be done. Thank you.
I'll reach out after the call. There's a researcher and a physician, Kathleen Unroe at the University of Indiana, is absolutely passionate about palliative care and nursing homes and has done some incredible work and developed training specific to the nursing home setting. So I'd love to connect you with that work.
Thank you.
Thank you so much. And a couple more questions here. One from Carly that's asking, what do you see the next major steps being in improving palliative care?
Well, so, I think about this in terms of a few fronts. So there's workforce is a question. We don't have as many trained palliative care specialists as we would want to meet the need. And I know this is a global audience. I think that's a challenge that we share across the world. So it's both about, I think, thinking of all of the strategies to expand the pipeline of people entering the specialty palliative care and to double down on these efforts to train all health professionals in basic palliative care skills. Nursing has made this more of an explicit priority in pre-professional training programs. That's a vision we hope to realize. And I will say the amount of palliative care education to non-specialists from my perch has really been accelerating in recent years. There are professional societies from other specialties who have taken an interest and are promoting palliative care skills development to their membership. There are large health systems in the US that have really invested in this kind of work, in equipping their clinical staff, for example, with the skills they would need to have goals of care conversations with patients.
Hmm.
So I think that's moving in the right direction, and the need is gigantic, and
Hmm.
there's a lot of work still to be done.
Hmm.
Um, we are, in terms of ensuring reliable, equitable access to palliative care, we are constantly looking for the policy or payment levers that would lead to accountability for access,
Hmm.
accountability to quality for palliative care. So
Hmm.
inside of Medicare programs, is certainly, would have huge impact. There are U.S. states, that are starting to take really exciting action inside of their Medicaid programs. Back to the question about, um, patients living in poverty or with few financial resources. Medicaid programs often cover healthcare for patients with very complex needs with few financial resources, and so it's very, very exciting to see states like California and Hawaii starting to pay for palliative care for that patient population. And there's I think again that state level activity is gaining momentum. um, so I think there's a lot to be excited about there. Um, and then there is a global community, I guess, as everyone on this call knows, of palliative care. I had the opportunity several years ago to visit Brazil and learn from the Palliative Care Association in that country about what they were doing. And they face many of similar challenges despite how differently our health systems are
Hmm.
constructed. So I think continuing to learn from one another and how we're innovating to continue to expand access.
No, thank you for that. And as we're coming to an end here, I guess a final question or two. One being, in terms of the metrics of success, then in seeing the success of the expansion of palliative care teams and programming, is it a matter of simply there just being more palliative care available, or what does success sort of look like in the coming years?
I'm laughing because I wrote a letter to the editor of the Journal of Palliative Medicine a few months ago, and the title was something like, "This is good, but we need more." So
Okay.
some of it is more. Um, and again, a larger workforce, better staff
Hmm.
teams. We CAPC collects data about where palliative care is and isn't, which healthcare organizations provide palliative care. It is the case that the large majority of of hospitals with more than 50 beds in the United States now have palliative care.
Mm.
So that's great. We look at where palliative care is being provided in community settings. Around 50% of US counties have a palliative care program that will make a home visit to that county. What that measure doesn't speak to is capacity. How many patients could that service follow in that county? What intensity of care could be provided? So again, there's been a lot of growth. We need
Mm.
more growth. What would make that happen is again requirement for access to palliative care or a sustainable payment model for those services. Um, and that's where our advocacy comes in.
Always important. No, thank you for sharing that. And seems like there's been good progress, but still need more.
Right
Um,
direction and still on a path. That's right.
yeah. Well, we are unfortunately slowly coming to a close of our discussion today. And before I wrap things up, would love to hear your sort of larger takeaway key messages from today's discussion. But I'll give you a moment just to gather your thoughts, and we'll introduce next week's guest speaker and topic. So we'll be joined by Ms. Sonia Singh, who's the Director of Community Health and Canadian Institute for Social Prescribing, CISP, Canadian Red Cross, and we'll be talking to her on supporting healthy aging through social prescribing. So very excited for that call as well. And then I'll pass the floor back to you for any sort of takeaway key messages that you want to share with our audience here today.
Yeah, I guess my key takeaway, I think back to my grandmother and not feeling listened to. I think we all intuitively know that your cancer or your dementia is not the entire story of your experience with healthcare. I think every clinician who enters healthcare does it because they care about people,
Mm.
not just a tumor. And the fact that we've, that the way that we've shaped healthcare has made it harder and harder to have those types of clinical interactions, to provide those types of services, is to all of our detriment. But I think, we look, for example, at support for draft legislation around palliative care workforce development in the United States. Both sides of the aisle are in favor of that because we all, at some point, develop an illness. We all face that experience. Our families face that experience. So I think, it's a, in some ways, it's about getting back to what healthcare is about. And that will help our advocacy efforts in the years to come.
Thank you so much for that. And thank you for being so generous with your time here today. It's been lovely to meet with you and have a discussion about creating more sustainable change and providing more care for those who are facing serious illness. So thank you again for all of your support and for another great week, everybody. I would also like to thank all of our dedicated attendees and the incredible staff of the IFA who helps support every Global Cafe, especially Luana. So thank you, Luana. But happy Friday, everybody, and hope to see you all on our call next week. Have a great weekend. Thank you.